Gunnerberg for this proposal. I am very glad to be able to exchange with you. It is written IACAPAP Perspective. Of course, I cannot be sure that this is IACAPAP Perspective. This is a perspective that I propose to you, but I have discussed about this presentation with some colleagues, and in particular Gordan, Harper, who is in the United States, and he is the treasurer of IACAPAP. I have no disclosure for this talk. So, first question, very important for IACAPAP, what is the current situation of child and adolescent psychiatry and mental health around the planet? The good news is that in the past we hadn't any data about that, and thanks to WHO, because of their burden of disease study of 2012, we have now data about burden of disease in child and adolescent psychiatry. And this burden of disease is estimated through dailies. In the past, you know, epidemiologists were only obsessed by mortality, and of course for child and adolescent psychiatry this is not the good outcome, but now we have disability adjusted life year, and this is much more relevant. And here are the data. Perhaps you cannot see that for America, Europe, Western Pacific region, the disease that induce the highest number of impact in terms of daily correspond to mental health and psychiatric disorders. After, for Africa, for Eastern Mediterranean region and Southeast Asia, the disease that induce the highest number of loss of daily correspond to infectious disease. In particular for Africa, where there is AIDS, malaria, and smallpox. But first, you can see that as all statistics, these statistics can be difficult to interpret because they have separated unintentional injuries to child and adolescent psychiatric problem. And you know that unintentional injuries can be related to ADHD, for instance. And the second point is that the impact of infectious disease in most countries is going to decrease in the next years. And so we can guess that for the whole planet, in the forthcoming year, it will be child and adolescent psychiatric problem that will correspond to the highest number of dailies. So now we have good data to speak with politicians about the burden of disease in child and adolescent. Since it is the biggest problem, why is there so little investment by politicians in our discipline? There are 4 reasons for that. 3 reasons are in a way sociological. First, many people consider that our job is just care. And so, you know, there is a curse of care. Care in most countries is considered as something that shouldn't be, that should cost nothing. Care is for women, for mother, and this is not a professional thing. And because a good part of our work is to do care, we have a drawback about that. The second point is the ambivalence toward kids and adolescents. You know, everybody is supposed to like kids and adolescents, but in fact this is more complex, as you know. And the third point is about anti-psychiatry. Anti-psychiatry does exist even in the 21st century. So, but we cannot change these things. This is very difficult. But what we can change is when we are a part of the problem. And indeed, we are a part of the problem. Why? Try to define what is your job and what should be your job in terms of clinical activity and in terms of research. Try to look at what we write in papers. In IACAPAP, we do like global mental health. I am sure you know this concept. The definition is that the area of study, research, and practice that places a priority on improving mental health and achieving equity in mental health for all people worldwide. This is perfect. And you have keywords, epidemiology, public health, etc., etc. So, okay, but you know this is not the only way to consider psychiatry. I have been on the website of the most important institution that deal with research in psychiatry and in child and adolescent psychiatry in particular. You know, it is NIAMH. And the objective of NIAMH is transforming the understanding and treatment of mental disease. This is excellent. But what is proposed to do that? Things about molecules, mouse, and genes. You know. And you know that the NIMH has proposed new criteria for mental disease that relies only on biological concepts. So, you can imagine a politician. On one side we say, well, global mental health is a good concept. This is fine. On the other way, look at, we are doing neuroscience. We are the champion of doing split. And so people don't understand what is mental health, what is psychiatry, what we are doing, what do we want in practice. So, why it is a problem? It is a problem because, in fact, you know that the core of our job is to work together. Child and adolescent psychiatrists, parents, of course, psychologists, nurse, social worker, judge, etc., etc. If we want to improve our treatment, we have to work together. And I think there is a consensus about that today. The problem is that, you know, all these people do not cost the same amount of money, of course. And so, for a politician, if there is everything in mental health and in psychiatry, but if things cost a lot and other things do not cost so much, so if we have to take decision, we will cut the spendings about people who cost a lot. And this has an impact in many countries. There is a tension between social business and clinical business is in tension because it costs. And this is a real danger for our future. So I come to the conclusion and to what should we do to struggle against that. First, I do think that to cement the collaboration between all our profession, we have to be clear about what is our job. And it is not so simple because there is a tension between psychiatry and medicine. What is the specificity of psychiatry inside medicine? And there is a specificity, but it is not clear. The specificity between adult psychiatry and child and adolescent psychiatry. We have not the same history. And you know that in many countries, about students, about mother-infant relationship, there is a tension between adult psychiatry and child and adolescent psychiatry. And we have to be clear also about this position. The individual and the societal. For ADHD, for instance, the situation is completely different when you have a patient in front of you and when you are a politician that is supposed to deal with the future of his kids and adolescents. These are two very different situations, and also we have to say it. And the last point, surely the most important, mental health is not the same as psychiatry. It is just in the definition of WHO. Mental health is related to well-being. Psychiatry is not related to well-being. It is related to treating patients, and this is not the same thing. To deal with suffering, this is not the same thing as making people happy. There is a correlation, but this is not the same thing. So first, we have to be clear about jobs and concept. And second, we have to roll up our sleeves. The main point is that to be together with all these different jobs, we have to transmit knowledge. It is a necessity to have a common knowledge. And IACAPAP involves a lot in this direction. First, you know, there is the e-textbook, which is an online free material where everybody can learn child and adolescent psychiatry at a high level. We have a MOOC now, massive open online course, that will be translated in 6 languages: Chinese, Russian, English, Spanish, French, Arabic, etc. And there is also networking, that is this congress where you are, and seminar, and we are planning also to do a research network, that is some kind of Facebook, but internal to the IACAPAP platform, where child and adolescent psychiatrists could exchange each with each other to discuss about their problem. Thank you, Norbert. Thank you all.